Hello, my name is Shelley Bledsoe, and today I'm going to talk about my organizational strategic project on Vanderbilt University Medical Center and readmissions reduction. This course is for Nurse 5060 Transformational Strategies Practicum 3. The learning objectives is for the audience to become familiar with Vanderbilt University Medical Center and the healthcare organization as a whole. We will also discuss VUMC's SWOT analysis that was part of my organizational assessment. I will provide an overview of my strategic project to reduce readmissions. I will describe the implementation of the project as well as outline the status and overall impact of the project on VUMC as a whole. So now we will talk a little bit more about Vanderbilt and its culture. Vanderbilt University Medical Center was actually formed in 1874 when the School of Medicine incorporated with the Vanderbilt University. In 1925, the School of Medicine actually relocated to the main campus, which is where it is today. And the main campus is what makes up the university, the hospital, outpatient clinics, laboratory, and library, as well as Vanderbilt Children's Hospital, which is where I work today. Today, Vanderbilt University Medical Center is a huge academic enterprise. Vanderbilt was named the #1 hospital in Tennessee by U.S. News and World Report in 2014. There are over 23,000 employees, making Vanderbilt the largest private employer in Middle Tennessee and the second largest in the state. Vanderbilt University Hospital alone has 966 beds with over 52,000 admissions each year. ED visits alone exceed 114,000 and clinic visits are 1.94 million per year. The mission of Vanderbilt is simply to shape the future of health and healthcare. Vanderbilt operates under 5 pillars. Each year, measurable goals are set related to these pillars. The pillars include people, service, quality, growth and finance, and innovation. If you were to ask a Vanderbilt employee about culture, the very first thing they are going to bring up is Elevate. The goal of the Elevate program is to establish a new culture of service to patients, colleagues, and to one another. Its mission is to strengthen leadership practices for recruiting, retaining, and developing and engaging a committed workforce that is dedicated to service excellence. Finally, the vision is to build a common culture based on service excellence and credo behavior across the medical center. Credo behavior is basically doing unto others as you would have them do unto you. It includes, I make those I serve my highest priority. I respect privacy and confidentiality. I communicate effectively. I conduct myself professionally. I have a sense of ownership. And finally, I am committed to my colleagues. It's who we are. As part of our organizational assessment, students were asked to perform a SWOT analysis on their organization. SWOT stands for strengths, weaknesses, opportunities, and threats. Vanderbilt has many strengths, including the diversity of services we offer, the fact that we are able to care for complex patients and disease processes. We offer patient-centered care. Vanderbilt is very innovative, always striving to use the latest and the greatest technology. We have a culture of continuing education, and we have a pretty good employee benefit package. Some of the weaknesses include the ongoing staffing shortage, particularly in nursing, that Vanderbilt is facing. The fact that we care for high complexity patients puts us at risk for CMS penalties. While we are very innovative, we have difficulty sometimes sustaining that innovation. Vanderbilt has also recently decreased benefits, which has caused staff morale and trust to decline. Finally, there's a political hierarchy that still exists at Vanderbilt that contributes to the disconnect between leaders and staff. I believe Vanderbilt has excellent opportunities for the future. Name recognition alone is huge. Most people have heard of Vanderbilt University. I also added innovation here because it is an opportunity going into the future. Growth, employee relationships, and the fact that Vanderbilt is going lean and plans to use lean methodology as their methodology for change in the future. Threats at Vanderbilt include the decreasing payer reimbursement rates, local competition. There is at least 3 other major hospitals within a very short 3-mile radius of the hospital itself. The electronic medical record, we're actually switching from a homegrown electronic medical record and going to be selecting either Epic or Cerner, and this transition will take place over the next 2 years. That is certainly going to be a threat to employee satisfaction and workload during this time. Finally, our hiring process is not where it should be, and space continues to be a problem. The organizational assessment yielded several strategic projects that would benefit the medical center. Standardizing the PCC operating model was one. PCC stands for Patient Care Centers, and patient care centers include heart, cancer, eye. There's several different PCCs within the institution. Another priority was sustaining innovation and QI initiatives. We are working towards this at Vanderbilt using the lean methodology that we will discuss further. Human resources and nursing executives are working on the acute staffing shortage as well. The project I chose and that we deemed to be most important was improving transitions of care to reduce 30-day readmissions. Readmissions cost both the payer, in this case CMS, the Centers for Medicare and Medicaid Services, the organization, and the patient a lot of time and money. And that is why we chose to work in this area. There was a great deal of evidence-based practice related to readmission reductions. What we found was that programs most successful in reducing readmissions enhance patient-centered care and discharge processes. They focus on medication reconciliation, improving the coordination of care, and patient education so that the patient can self-manage their own disease process. We also found that strategies commonly recommended for reducing readmissions include improved patient education about their medications, patient-centered discharge instructions, follow-up telephone calls and home visits, as well as increased coordination with other outpatient providers. Finally, no single method has been found to work on its own to improve the reduction of readmissions. Rather, it's a combination of methods that yield results. The direct mandates of readmission reduction include that 20% of Medicare patients are readmitted within 30 days, costing $17.5 billion annually. The Hospital Readmission Reduction Program enforces penalties on hospitals that are over the risk-adjusted norm. The VUMC Heart Patient Care Center drives readmission rates and the penalties because they are the primary provider of both heart failure and AMI diagnosis-related groups. In the coming year, CABG and PCI are also going to be areas that are available to be penalized. The indirect mandates include that we have a reduced workforce which restrains the efforts of readmission strategies. The Heart PCC is a driver, but no additional resources have been provided for us to do this work. Another indirect mandate is that we are to provide consistent and accurate metrics, report these, but it's hard to keep up. Finally, there's a broad evidence-based practice recommendations regarding reducing readmissions, but there's no set practice or pathway to follow. It's not do this and you will lower your readmission rate. So now we're going to talk briefly about the project. The basis for my project is simply to improve transitions of care for patients with heart failure and AMI to reduce 30-day unplanned readmissions. Readmissions are burdensome to both patients and hospitals. An unplanned readmission is a huge patient dissatisfier, and it's very costly for the health organization, not to mention CMS. The Affordable Care Act established the Hospital Readmission Reduction Program in 2012, and it allows CMS, the Centers for Medicare and Medicaid Services, to reduce reimbursement to hospitals with excess readmissions. In the first year, 61% of all hospitals were penalized. The Patient Navigator program is part of the American College of Cardiology. The Patient Navigators program's goal is to reduce readmissions using a patient-centered and team-based approach to improve care for cardiovascular patients by leveraging evidence-based practices. For hospitals participating in this work, they are awarded $160,000 in grant money. Vanderbilt University Medical Center and Vanderbilt Heart and Vascular Institute was among the 35 participating hospitals chosen to do this work in improving transitions of care to reduce readmissions. So my strategic project, also called the Patient Navigator program, is very exciting work and has the potential to greatly impact the organization. However, there are threats to this project. The actual threats include dedicated resource, scope of the project, documentation and tracking the work completed. Also the fact that we've gone through a big reorganization within Vanderbilt Heart and Vascular Institute. We've had turnover of the executive team. Myself as the project lead has taken a new position, so I am now located in Vanderbilt Children's Hospital, and our data analyst left Vanderbilt. The potential threats include the duration of the project. This is not a short-term project. It actually spans 3 years, with 2 of the years being actual implementation years. We have unknown readmissions to other facilities, which are a threat to Vanderbilt, as well as patient compliance. Finally, accountability is also a threat. Lack of indecision and decision-making by those that are involved in the project, as well as lack of follow-up. Some of the prevention strategies that we have put in place include limiting the scope of the project to just 2 key goals. As far as resources and reorganization, we have found that we just have to have excellent communication and regular meetings and follow through. For documentation and work progress, we developed a SharePoint site, so all the work being done on the Patient Navigator program can be found in one place. And it's highly accessible. Whether you're working in a different department, you're working from home, you have access to that information. Accountability is another prevention strategy, and it just includes meeting agenda and minutes with task assignments reviewed at every meeting. Finally, for patient compliance, we are really focusing on nursing education for these people, on medication reconciliation, etc. Internal stakeholders include VUMC organization and executive leaders, VHVI faculty and staff, the Patient Navigator Readmission Task Force, case management, and heart failure and AMI patients and their families. The external stakeholders include the American College of Cardiology Patient Navigator program, as well as outside physicians and healthcare facilities. Driving the adoption of this program was CMS's Hospital Readmission Reduction Program, as well as the fact that VUMC chose to participate in the ACC Patient Navigator program, thereby receiving $160,000 in grant funds. The approval came from Robin Stephen, our Chief Nursing Officer, Wright Pinson, the Deputy Vice Chancellor of Health Affairs, as well as the Contract Management Office. Project Team. We have 3 sets of team members within the Patient Navigator Task Force. The executive team includes myself as project lead. We have an executive leader, Marie Glasser, who is the Associate Nursing Officer of VHVI, as well as physician leads, Dr. Board, Dr. Mark Glazer, and Dr. Joanne Lindenfeld. The core team includes Lena Spiga, Tiffany Street, Brenda Reed, Christine Lai, Michael Cornelius, Jay Morrison, Carol Parsons, and Mary Stroud. They make up the body of the task force. And then finally, we have internal consultants that we call in on an as-needed basis to participate in meetings. Change theory. As previously discussed, Vanderbilt University Medical Center is going lean, and they are using the lean methodology for change. Lean is a management philosophy based on 2 tenets: continuous process improvement and respect for people, with the focus being on eliminating waste. Now I'm going to share the project timeline with you. The project timeline for the Patient Navigator program actually spans 3 years because we had our kickoff on acceptance back in January of 14. However, our first official site visit and program start was not until January of 2015. So we are about 25% of the way through the program based on the start date of January of 2015. We actually started the implementations for improvement in July. As previously mentioned, we've decided to limit the scope of this work to 2 goals. Our aim is to reduce avoidable hospital readmissions for patients discharged with acute coronary syndrome, acute myocardial infarction, or heart failure by supporting a culture of patient-centered care during the hospital stay and in the weeks following discharge, and thereby reducing both mortality and improving quality of life. The first goal is to improve the number of patients that are provided follow-up appointments within 7 days of discharge before they leave the hospital. And the second goal is to improve the number of patients receiving a post-discharge phone call within 72 hours of leaving the hospital. Regarding our first goal of improving the number of patients that are provided follow-up appointments within 7 days of discharge before leaving the hospital, the current issue is that 33% of patients with AMI and 35.2% of patients with heart failure is the amount that actually leave without appointment in their hands. Strategies and interventions include implementing an estimated date of discharge, defining a standard process for reliably scheduling these post-discharge appointments prior to them leaving the hospital, as well as identifying options to create capacity to accommodate 7-day post-op appointments. We're looking at increasing nurse practitioners' scheduling templates for this. For the second goal of improving the number of patients that receive a post-discharge phone call within 72 hours of leaving the hospital, we found that the percentage of patients receiving these phone calls, only 20% of AMI patients and only 39% of patients with heart failure currently receive these discharge phone calls. These discharge phone calls are where we are following up on medication reconciliation, education, etc., things that are important to prevent readmissions. Strategies and interventions include reevaluating the existing processes for nursing staff that are completing the follow-up phone calls, revisiting the processes and selection of patients that are placed in the queue to call, conducting a deep dive to understand the processes and variables of the call itself, and then finally redesigning the whole process to create a reliable process for completing those discharge phone calls. Barriers of the implementation have included VHBI turnover, a lack of dedicated resource, selecting strategies that are under VHBI control, following the patient navigator guidelines, as well as compiling the data for their quarterly submissions. For our project evaluation, we're using numerous methods of data, including the Centers for Medicare and Medicaid Services data, our ACC Action Registry report, the HCAP scores, as well as the self-reporting component that was a tool that we developed in REDCap that has over 60 data elements that we capture on every heart failure and AMI patient. REDCap is a web-based application that allows users to design and manage surveys for data collection. Vanderbilt is approximately 25% of the way through the Patient Navigator program, and though it can be frustrating because our progress is limited by having to follow the Patient Navigator program guidelines, so strategies and interventions did not start being deployed until July 1st, 2015. But this was right in line with the Patient Navigator program and took place after our second site visit and the finalization of our 2 goals and strategies. Finally, we are to submit quarterly data reports, and then the first quarterly submission is due August 31st of 2015, and this data pull is in progress. According to Medicare.gov Hospital Compare website, right now the Vanderbilt rate for readmissions regarding acute myocardial infarction is 16.4%, which is less than the national rate. Also, for heart failure, the Vanderbilt rate is 21.2%, which is less than the national rate of 22%. Therefore, for this fiscal year, we are not getting penalized by the hospital readmission reduction program. As far as self-reported data, as I mentioned, we're in the progress of pulling our first data other than the initial baseline, and therefore I don't actually have an update to give on the progress made on our 2 goals. I do want to reiterate though that because the interventions did not begin until July 1st of 2015, I'm not expecting the first quarter to show any changes from our baseline. As far as this project's impact on the organization, I hypothesize that by improving transitions of care in patients with AMI and heart failure, we will reduce 30-day readmissions. We anticipate that we will also improve patient satisfaction scores, and by reducing readmissions, we will prevent VUMC from further being penalized by the hospital readmission reduction program. And finally, by improving the workflow processes, we believe we will ultimately improve employee efficiency as well as employee satisfaction. In summary, Vanderbilt is a large healthcare organization that's located in Nashville, Tennessee, and provides diverse and complex care to patients throughout the Southeast region. Like every healthcare organization, Vanderbilt has strengths and weaknesses. However, Vanderbilt has also continued to thrive despite the significant economic challenges that we face in healthcare today. The Patient Navigator program is aimed at improving transitions of care to reduce 30-day readmissions in patients with heart failure and AMI. I have found that managing a strategic project of this size requires collaboration, consistent communication, as well as organization. Vanderbilt believes that by going lean and using this methodology to drive change is likely to improve both problem solving and produce sustainable change across the organization. VHBI is in the implementation phase to improve these transitions of care to reduce readmissions. The data is submitted on a quarterly basis for continued evaluation of progress. And finally, I believe the strategic project of reducing readmissions will likely have a large impact on both VUMC's bottom line as well as patient satisfaction. So for our discussion, I have a couple of questions for the audience. The first question is, do you think the improvement efforts around the current goals set by VHVI Patient Navigator team will reduce 30-day readmissions at Vanderbilt? And secondly, I would like for you to compare and contrast the lean methodology to the change theory used in your own organization. Which do you feel is better and why? On the screen, you will see the references used for creating this presentation and the work of this project. Thank you so very much for listening and learning about Vanderbilt University Medical Center as well as my strategic project. Have a blessed day.